Hello, and welcome to Hospice Insights, the law and beyond, where we connect you to what matters in the ever-changing world of hospice and palliative care. Quick takeaways from the 2024 proposed hospice wage index rule. So, Andrew, happy to have you. I feel like we are the wage index people. And so I feel like we've talked about other wage indexes on the podcast, but thanks for joining me for today. While this rule, I think, has less in than maybe rules past, there were some interesting things in it. Obviously nice to get a proposed wage increase of 2.8%. But I guess any thoughts on the wage increase before we get to, some of the more substantive things in the rule?
Well, yeah, very happy to be here. And actually my first ever podcast
yes.
appearance was on a hospice wage index rule.
That's true.
That was the one,
like a week
the addendum.
in. Yeah.
Yeah.
Jump right in. Did a great job.
Yeah, we did see a 2.8% increase to the different per diem rates. I was reading that some were maybe expecting a bit of a higher rate increase, but 2.8% is what we got. I will say too that CMS kind of did indicate, which isn't a policy change, this is a statutory requirement, but CMS did sort of remind everyone that beginning this year, the penalty for not getting your hospice quality reporting program data in is now 4% rather than 2%. So again, that was expected, but CMS wanted to remind us of that.
Yeah, well, and I think that in recent years during COVID, we did a lot of HIS appeals because COVID wreaked havoc on people's ability to get that in. I don't expect those types of issues moving forward, most likely, but obviously that penalty for not being able to comply, 4% is definitely a hefty penalty for folks, because I think budgets are really tight with staffing costs and everything like that. But so let's get into, speaking of COVID, some of the COVID flexibilities. I think most importantly is the telehealth face-to-face allowance that you could do the face-to-face via telehealth during the pandemic. Obviously, the pandemic is coming to an end here. Why don't you tell us a little bit about what the rule does related to extending that as an option?
CMS in the proposed rule, they would update the regulation now to say that hospices can continue using telehealth for the recertification face-to-face visit through the end of next year, so through the end of 2024. As just a brief bit of background, because this actually isn't a policy change. So originally, hospices could only do the telehealth face-to-face visit through the end of the public health emergency, which I think everyone now knows it does end. The last day is May 11th, 2023. So that was the original policy. The Consolidated Appropriations Act of 2021 actually extended that to the end of 2024. And CMS's sub-regulatory guidance, like the various publications already are referencing that end date. So this is really just, even actually in the rule, CMS calls this a conforming change. So again, not a policy change, but just updating the regulations to reflect that current policy, which is we can use telehealth for the face-to-face visit through the end of next year.
Well, and I think that the hope is that will become a permanent change, but I think that Congress needs to make that statutory change permanent. But The fact that they're extending it to 2024, and it's not tied to the pandemic, seems like they're indicating that this meets their regulatory purpose of why they wanted to do face-to-face visits, and that, and really, can you put the cat back in the bag, so to speak? Because I think telehealth was used so much during the public health emergency that I think it's hard to say that we can't use that effectively and especially the more limited goals of the face-to-face visit. Obviously, there's still going to be the practical challenges, right, of do our patients have that technology to use, and can they use that technology? Do they have a family member to help them? I mean, there's a lot of, the underlying practical issues, but so that's a definitely welcome change that hopefully in the future will become permanent. What about the virtual visit? So that's something that was also made clear during the pandemic, that you could do visits virtually. So nursing visits could be done virtually, but you weren't supposed to put those on the claim form. What are they saying about that in the rule?
They are actually removing that provision from the regulation. So that proposal did originally extend through the end of the public health emergency. That is continuing to be the case. So in the proposed rule, CMS, and these would go into effect October 1, 2023. So, when CMS finalizes that, they'll actually remove that regulatory allowance from the regulation, because by that point, it would already have been expired. So, but yeah, you're right. So this is that current flexibility only for routine home care patients, but we can provide care remotely, not even through the higher telehealth standard, but through any remote communications technologies, as long as the care plan, references the need for that. It has to be a patient-specific need, so it can't be kind of a blanket policy. But yeah, unfortunately, that allowance is ending here in about a month or so as of this recording date, unlike for the telehealth face-to-face visit, which again extends for another year and a half or so after the end of the public health emergency.
Andrew, this was a sort of out of left field for me, was this new enrollment, which, just as a side note, I mean, the amount of enrollment things that are happening based on that ProPublica New Yorker article, there's a lot of recommendations about focusing more on enrollment issues and deactivations of provider numbers that aren't being used and all that. And we're actually seeing that come up very quickly, even though these are more recent recommendations. Well, this is a little bit different spin on that issue. I was surprised to see enrollment come up specifically in the proposed rule. So tell me what they're doing with enrollment here as it relates to physicians.
Yeah, I agree with you. Kind of out of left field for me too, but what they're proposing is that any physician who certifies a hospice patient must be enrolled in Medicare or have a valid opt-out from enrollment, and that is a condition of payment for Medicare hospice services. So CMS actually is going to be, if they move forward with this, going to be revising the regulations to explicitly require, hospice physicians, attending physicians, anyone who is certifying a hospice patient to be enrolled in Medicare or have a valid opt-out.
And when you and I saw that and have been talking about that, anytime, CMS is saying this is a condition of payment, obviously, in terms of priority from a compliance perspective, high priority. And then how do you operationalize this? So I don't think that many folks out there probably have volunteer medical directors anymore, like retired physicians that are performing medical director services for you. But, in the olden days, like that was the case. And those people would not have been enrolled in Medicare, right? And it wasn't really an issue. They didn't do any billable physician visit. It just wasn't an issue. And that was okay, right? And so now I think this whole valid opt-out, I mean, there's a way to do that and a process to do that. But I mean, there's going to be some red tape around that. But I think the more pressing issue for folks is someone lists on their election form an attending physician. You need to find out, is that attending physician actually enrolled in Medicare? And as we see the rise of concierge medicine and other things, especially different pockets of the country where that's a bigger thing, where we have physicians who don't want to participate in Medicare, how you need to have a system like straight away that looks to make sure that this person is enrolled in Medicare. And also, if they're not, like, how are you going to deal with that? So there was some musings on this with the proposed DEA rule about had like people who are going to be ordering narcotics, like looking at do they have a current DEA number and things like that. If they're a referring physician and you're relying on their in-person visit to qualify for, why. I mean, this is a whole nother rule that was very complicated that just came out, but it was that same sort of practical issues. Am I checking everyone's DEA number that it's active if you're a referring physician to me or something? And here's this list of, is this person actually enrolled in Medicare? And, not insurmountable issue, but just from a processing standpoint, in the compressed period of time we have to do stuff, right? Like, I was just talking to a client earlier today, and like their median length of stay is like 6 days or something. I mean, so you don't have lots. Obviously, you have to get a verbal within 2 days, but like you have an admission on Friday. Like, there's just a lot of I think operational challenges thinking through, if this is not part of your current process, how do you do that? And so anyway, I'm concerned about this.
Mm-hmm. Yeah, no, I share your concern. I mean, of course, under the regulations, if a attending physician is unavailable, or a chosen attending physician is unavailable, then essentially there isn't a attending physician, and the hospice physicians manage care. So, CMS doesn't get into this in the rule, and I think it does create some confusion. But right, like, what if a patient selects an attending who isn't Medicare certified? Do we treat that attending as unavailable?
Or they don't have one, like, because they
that they
can't
don't
even
have one.
accept the
Right.
the post for purpose. Because essentially they're saying, for you to be a certifying physician in hospice, which, only, when you step it back, like, you're an attending physician if you're certifying them in hospice, right? Because that's the person we have to get the certification from. It's like, if you're not enrolled in Medicare, you can't really continue to be their attending physician in the Medicare context, right? I mean, because they're not qualified. So it's sort of like you pick a physician who's unlicensed, right? Like, you can't just say, okay, well, sure, they can be your attending physician. So anyway, I think that you and I had some ideas about both how this should be clarified, but also perhaps, and we don't need to get into it on this podcast, about how you deal with that operationally. Because if you're in an area where there's a lot of concierge medicine, because I just think that that's probably where this is going to come up most often, because obviously most people are enrolled in Medicare, but there are situations where obviously parts of the country where, you have people that can afford to use physicians that are not in Medicare and want to do that. And then how do you deal with that?
Yeah, I mean, off the top of my head, I can think of a few ways that CMS could have, even if they wanted to move forward with this idea, that there are some ways that they could have kind of set this forth in the rule that would have, avoided some of these concerns that we're talking about here. So overall, disappointing proposal, and the way in which it kind of came out, I think, could have been better. So yeah, that was a bit of some bad news, I guess, that came out of this proposed rule.
Commenters hopefully will focus on that, about, well,
Yep.
what are you trying to get at? I mean, I think their purpose of doing this is probably getting at folks, who might be fraudulent or doing something improper, right? People
Yep.
who've been excluded or not enrolled, or, whatever. But, I think the broadness, perhaps, again, I do think there's just, in certain parts of the country, physicians who just choose not to be enrolled in Medicare. And so that is also the case with Medicaid. And we've seen this issue on Medicaid audits where they're saying this person wasn't specifically enrolled in Medicaid, but they're certifying patients. So anyway, I think that reading the tea leaves here, I mean, we're just going to see within hospice, but also more generally just focus on enrollment issues, right? I mean, we have the affiliations rule that's now a lot of years old, that CMS finalized about trying to get at, who really owns companies and stuff, and keeping bad actors out, and trying to sort of understand people's relationships to various organizations, and that rule hasn't been fully implemented, but clearly this has been going on for a while, that we need to do more than like pay and chase. We need to have people be more transparent in terms of reporting enrollment and using enrollment, I think, more as an active tool. So I guess word to the wise, in general, everyone should be keeping up to date on their 855s, like, just because even this, in the last 2 weeks, we've had 4 enrollment issues. Some of them they're different variations, but it is very clear that the MACs are starting to focus on, and this is happening even in nonprofits, like, what's your ownership information that you report on this provider number versus this provider number, but they're sort of owned by the same thing. They're looking for veritability. And so I think there's clearly a push that the MACs are going to be looking at enrollment in general. So anyway, I think that has not been on folks' radar screen as much, keeping their 855s up to date with even the smallest of changes. And I think it's going to be more resources in that area is going to be important. And if this change really goes into effect, having a system at the get-go of who is enrolled in Medicare, to now most people can run a report out of their EMR that says, here are all the attending physicians that have served in the last 5 years. I'd see if you can run those numbers. Are all those people Medicare certified? Then this might not really be an issue. I mean, that doesn't mean they're going to stay Medicare certified and you don't need to look at it, but even to get a sense, because this is not something most folks have been sensitive to. Obviously, from a hospice physician standpoint, most of our physicians, because they may bill, I mean, they are enrolled in Medicare, and because we're not typically using volunteer retired physicians. So I really think it's the community attendings that's going to be sort of the operational issue, but probably your compliance folks can be doing some looking right now to say, how much of an issue is this really for me? Because are there anyone that has in the past certified patients that are not enrolled in Medicare? But I think good point, when I was talking about this with some other folks, of when you're dealing with fellows or residents or something who are licensed doctors but aren't yet enrolled, like, how do you deal with that? And I haven't thought that much about that. So I'm just throwing out like possible issues to consider. But even that, hopefully that would pop up too if you ran something from your EMR about who are my certifying physicians, to get a sense of, what could be the issues if this is really finalized in this way with no further clarity. So anything else, I guess, Andrew, in the rule? There's a lot of stuff about data analytics and quality reporting, and I think it just shows greater sophistication that CMS wants to have in showing value as we move to value-based care. Like, how can I measure this, and what outcomes are you really achieving, and things like that. But other thoughts on the rule before we wrap up here?
I guess I'll point out in passing here that CMS continues to focus on the Medicare hospice bleed out, the amount of money that's spent on hospice patients outside of the hospice benefits. So that's been a kind of a priority for the government, as we all know, in recent years. I think it continues to be so. It's discussed in here as well. And then I guess lastly, I'll just say comments are due on May 30th, 2023. So yeah, I mean, people are encouraged to comment, whether it be on that enrollment piece that we talked about or other areas of interest. That's always welcome. But yeah, that's sort of the rundown, I guess, of the proposed rule.
All right. Well, I guess it could be worse, right? So
Well, that's always true.
Right, we're lawyers. We need to be pessimists. Well, it always could be worse. So it wasn't nothing, but obviously when we had all the election changes and stuff, I mean, those were really, really, and the whole addendum, I mean, those were much more fundamental changes and just I got to get new forms printed. This obviously the enrollment piece is going to have some operational details and, the quality reporting, future stuff. I mean, that's which we don't get involved in as much. But anyway, I just think, especially when home health got a huge rate decrease, the fact that we're still getting an increase is, helpful. But it's probably, as you said, still not enough. So anyway, that's how lawyers end things. It could be worse. Sometimes, well, I don't know if I've ever said, no, this is the worst it could get. So I'm trying to think in my 23 years.
Maybe one piece of optimism, CMS, I think they did propose, not just for hospices, but for kind of a bunch of provider types, this kind of Medicare enrollment requirement a few years ago, and they ended up not finalizing it. So I guess it isn't a foregone conclusion that CMS finalizes this hospice specific enrollment piece, but
you're so bright-sided. You're like just a breath of fresh air. So no, but going back to your point this is why it's important, for association, to be involved in associations who write comment letters. I mean, individual providers, as you said, can write comment letters. I think oftentimes people don't go ahead and do that, but I think getting your voice out there, because this is the whole reason why there's a rulemaking process, right? CMS, the government does want feedback. If they're going to make a substantive change, they got to propose it and they got to, hear what the people who they're regulating have to say about this. And I think, that process itself demonstrates that, as the government, they don't know all of the operational hurdles or concerns that go along with their recommendations, right? And so you can have positive influence, and not everything they proposed gets pulled through. So love it. That's a great place to end. I'm now going to become the optimistic lawyer. That's going to be my new tagline. Terrific. So, well, thanks for sharing your wisdom here, Andrew. And until next time.
Thanks, everyone, for listening.
Well, that's it for today's episode of Hospice Insights, The Law and Beyond. Thank you for joining the conversation. To subscribe to our podcast, visit our website at hushblackwell.com or sign up wherever you get your podcasts. Until next time, may the wind be at your back.